So I would like to introduce then my co-chair, Professor Paolo Piccaluga, and he will talk about the role of artificial intelligence in digital pathology and cancer diagnostic. He is indeed a pathologist, and so who better than him can tell us how artificial intelligence can help us in interpreting the images. Dr. Paolo Piccaluga, please, the stage is yours.
Thank you very much, Professor Isidoro. Thank you, Frida. It's indeed a pleasure to be here today. Hope you can see my screen. Pathologist as introduced, and I'm quite fascinated by new technologies and particularly the role of artificial intelligence and digital. So today I wish to share with you some of my thought, and I'll try to introduce the subject, not going into some details of cancer diagnostic that later on our colleagues will describe to us. However, before getting into the model of pathology, I will give you a little excursus on the history of pathology. How did we get to digital pathology throughout the history? And as you know, pathology is basically the discipline studying the morphological changes in the body, in the organs and tissues related to different diseases. So the origin is indeed ancient and relied for a long time on post-mortem observation. And even though here in Western countries, we tend to refer most of the history of pathology and basically of medicine to the ancient Greece, we should acknowledge that during the Islamic Golden Age, so quite earlier than the Hippocrates time, Avicenna wrote the canon of medicine and described some of the pathologies that we currently recognize. And later on, an Arabian physician, Abenzoar, described and performed the first post-mortem dissection as we consider it today. Later on, in the ancient Greek, we had the huge work, of course, of Hippocrates, but then later on, Herophilius and Erasistratus, they performed on their side careful human dissection and described the organs during pathology. But a big role was played in Italy during the Renaissance, and particularly Giovanni Morgagni published a book based here on the evidence. We could consider it as one of the first real scientific publication in the history, as it was based on more than 600 autopsies. With time, pathology did evolve, and the major change was the shift from the macroscopic, just postmortem examination, to the microscopic examination of tissue at the microscope. And the key figure in this regard was Rudolf Virchow, that described extensively, put the basis for cellular pathology. But moving more specifically to cancer diagnostic, of course, we started from the clinics with the clinical examination, palpation of the tumor, which means mass, the visual inspection, to more evolutive techniques, and then the role of pathologists with the biopsy, and particularly the role of microscopic pathology implemented, and we know the impact that immunohistochemistry had on cancer recognition and classification in the recent years. As an hematopathologist, they can certainly witness that without immunohistochemistry, a large fraction of what we know about hematopoietic cancer would be neglected. And then the real modern detection of cancer biomarker with molecular diagnostic and molecular pathology. And now we're entering in this decade to the era of digital methods. But what are really the challenges and unmet needs in cancer diagnostic? I believe that during the last century, the last 50 years, tremendous improvement have been made in cancer diagnostic and treatment. However, we should still remember that roughly 50% of our patients with cancer, they still die of their disease. So of course, the unmet needs are certainly large. And I think that some of the most prominent issues are the early recognition of cancer, because still for many solid cancer, early recognition is the only way to cure. Currently, we need a tumor, as we defined it, a mass, visible mass or symptoms to diagnose the process, and this is sometimes too late. We need to improve our exact diagnostic. And in this regard, I would to underline, as an hematopathologist, that still pathology is still largely subjective. The expert opinion, the opinion of pathologists, not just relying on an objective test or just measure of something, is still dominating the pathology field. So it's implicit that in certain instances, being available a super expert in a certain disease, a patient can benefit of a super diagnostic, of course, but in several instances, maybe for lack of expertise on a specific subject of pathology or related issue, patient cannot benefit from an optimal pathological diagnosis. And this, of course, would translate in the lack of exact treatment, because if you lack exact diagnosis, you certainly cannot identify the exact treatment. And particularly, even when the diagnosis is good, maybe we still lack molecular targets that can predict the best treatment and the most likely outcome for patients. And in this regard, at least for what exact diagnosis, objective diagnosis is concerned, digital pathology may certainly play a role. But if we consider patient journey and doctor journey throughout pathology, from morphology to immunophenotyping to molecular pathology, where do we place digital pathology and algorithms? Well, if we compare the standard approach in which the tissue is processed, goes to slide, and the pathologist will perform the examination and reporting, with digital pathology, we just add a very early, I would say, element. In fact, as soon as the slides are ready, they can be digitalized through scanners, and then the pathology can, on one side, examine the slide not only at the microscope, but also using tools on a screen, and can, very importantly, share real-time, whatever the convenience, the images to other colleagues for easy consultation and case discussion, as it commonly happens for clinical things. But considering digital pathology, we should also consider what is included in the term of digital pathology. So first of all, the basic is the use of digital images and platform to develop and analyze them through computers, and then how this can improve our diagnostic ability, that probably cannot just rely on having a bigger screen instead of the microscope to analyze tissue. The benefit that we can anticipate, they are, as I said, probably a better image analysis and more accurate diagnosis. This would translate in diagnostic accuracy. But also the global collaboration is quite important in my view, leading to routinary use of telepathology. As I'm currently working and dealing with issues in biobank, if you consider that we can currently explore biobanks, of course, in this biobank, very famous and renowned, there are available 100 cases of breast cancer. Now, I'm sure that most of you would agree that it's quite difficult for a researcher to analyze, maybe investing a lot of money, maybe for next generation sequencing, metabolomic, or whatever, on cases that we cannot really revise the diagnostic point of view, assess how much tumor cells are in the tissue, what the reactive components are. So having, let's say, a window, like in a shop with digital pathology, would increase the use of biobank and increase, therefore, research worldwide. But very importantly for academicians, as some of us are, is the training possibility with digital pathologists. In fact, right now, the training in pathology is limited by the number of microscopes, by the availability of specific cases in a given center. very easy to have a large portfolio in the biggest hospital, but then when we go to smaller hospitals, smaller university, and maybe less developed country, could be very difficult. With telepathology, we may train our young doctors with basically unlimited cases, including rare diseases. We could study particular diseases with complete reports that were made by experts in the field. So expert diagnosis and 24 hours per day remote access. And this is useful also for doctors because, of course, digital pathology will make easier to have a continuous education and training with new methods and cases. But as I said, it's not just a matter of having an image, a digital image, but here is the integration with artificial intelligence, and particularly artificial intelligence and machine learning and deep learning context in pathology can be used to train the machine to recognize specific images in our setting and later on to integrate them with other data. So putting together morphology, immunophenotype, and even genetics and clinical data, which is basically what we currently do in our job and can be, I wouldn't say substitute, because I don't really believe in substituting people by machine, but I totally believe in implementing and integrating their job with a very powerful system. And indeed, artificial intelligence can recognize patterns. So what is a pattern? Pattern is something that we first of all need to recognize. So machine cannot replace the training period for the machine itself that expert doctors has to do in order to recognize our cell is shape, our cell is color, the cytoplasm, the presence of granules, the nuclear shapes, and therefore we can establish an algorithm and then validate with clinical cases. Currently, it is estimated that 10 to 20% of pathological analysis benefit, at least in part, worldwide, of artificial intelligence in digital pathology. It means that 1 or 2 out of 10 pathologists, they currently use digital images in the clinical world. However, if we extend our investigation, our description, not only to the most advanced center in the US, Europe, and Asia, but we get a worldwide estimation, we can evaluate a little bit lower extent of diffusion, like it's 5 to 10%. But I believe that 5 to 10 is already a relevant step if we consider the setting. But now, giving you a couple of examples how artificial intelligence and digital pathology can work. Here we have squamous cell mucosa, and how can we train our system to differentiate cell types? Here, with the color code, we can see how in blue we may enable the system to recognize the mature squamous epithelium, how in green we can recognize the basal layer, and immediately our thought can go to the recognition of dysplasia and early cancer in squamous cell carcinoma, in which the basal layer is expanding and extending through the deepness of the epithelium. And then in the yellow, even the spongiosis and the non-cellular spaces are recognized. And finally, the lamina propria. So we can train the system to recognize cells. And of course, this can translate when you deal with pathology to the recognition of cells that are not supposed to be in the tissue. So once again, starting for a squamous cell mucosa here in the esophagus, we can recognize here, depicted in green, eosinophils that are characteristic of some phases of acute esophagitis, but also of the chronic eosinophilic esophagitis. And by contrast, other cells, like the squamous cells of the epithelium, can be distinguished and numbered. And when we put together the single cell with the pattern of aggregation of cells, we can even recognize small abscess through the layers of the mucosa. So really interestingly, at least on the basic of the analysis. But you may argue that recognizes normal cells is obviously easier, but I would also stress that in order to recognize a pathological pattern, you have to first distinguish that it's not normal. So having a baseline recognition of what is normal would certainly help to recognize what is not, and this is what is happening in cancer. Intriguingly, we cannot just claim that since we are using a machine, we are improving our capabilities. And even if in the clinical medicine, we know very well the phase 1 trials assessing toxicity, phase 2 with the balance of toxicity and efficacy, and then phase 3 comparing in the randomized trial the new product or system to the old one, and then the observational for long-term toxicity. In diagnostic, I dare to claim that very few researchers, they really know and use properly the diagnostic accuracy study, in which the phase 1 and phase 2 are usually something inside the companies that they develop tool, because they serve to describe sensitivity specificity, which is the identification of a target condition and the confirmation that the presence of a given condition when our test is positive. And so we usually start from phase 3 and phase 4 with a comparison to a gold standard, and the comparison not only to the gold standard, but to the clinical outcome. And this is the aim for artificial intelligence. If we want to use it in routine, we need to demonstrate that it will give us benefit compared to the gold standard. And I think, honestly, that this would be still a long road, because we need studies for that, not just little application and single sample. But some papers have been come out already, and they dealt with several subjects. I will go through a few of them. First of all, the recognition of melanoma for an improved diagnosis. And starting, this is a large study enrolling more than 400 patients, and the system based on digital images analysis show it a sensitivity of 97%, but however, a specificity of only 37 for melanoma, because still confounding different tumors. But on this regard, of course, human could then place the own diagnosis, so that overall, the ability of doctors was increased in a significant manner when digital images was added to the conventional routine. So once again, not substituting, but offering an additional tool to doctors. And interestingly, we all know that macroscopic examination of melanocytic lesion is the first step for diagnosis of melanoma. And there are patients, there are studies now showing the digital analysis of single patient and comparison of them can easily detect the appearance of new lesion of the increase in size of some of them. So very importantly in the dermatological examination. But one of the settings in which digital analysis has emerged most prominently is the evaluation of lymph nodal metastases. And here an example in lung cancer. Of course, we know that detection of micrometastasis is quite relevant because it's changing quite dramatically the prognosis for our patient. And here you can see the cells that are highlighted here, what's visible microscope, could be analyzed and detected. Here you see the green dot in the digital setting. And indeed, once again, in this relatively recent study, it was demonstrated that digital recognition of metastatic cell in lymph node is feasible with high accuracy. However, no proper comparison with only humans was made, so we cannot consider it still a phase 3 diagnostic accuracy. For other settings, there is a tremendous, I think, for the time being, amount of study showing the potential of the system. In fact, you can see that the accuracy in the recognition of lymph node metastasis varies from very high, 90, 95, up to 99 and more % in different studies. Of course, we should go deeper and evaluate how those metastases were visible at the microscope. Of course, if it's an obvious metastasis, it could be easy to recognize. But on the other hand, recognition of easy patterns could make the job of pathologists easier just by solving easy cases and leaving the time to pathologists for the more complicated one. So I would not neglect the possibility of, let me say, easy recognition of obvious pathologies in some instances. Another field where we are applying digital image analysis is prostate cancer. Now, for the recognition of invasion and microscopic areas of invasion, this is currently even under evaluation for approval in the current use, and there are several different approaches. You can evaluate the proliferation of cancer, you can evaluate the extension, and as you can see, different studies that included tremendous number of slides, say 25,000 slides, to smaller one, but still including relevant number of cases on the clinical point of view. So showing how the machine developed algorithm could improve the diagnosis and drive, here is the translation to the clinical use, how could drive some therapeutic intervention. But of course, it's not all a success. There are still several issues. The first, I would consider the ethical and legal consideration. So when we digitalize images, we need to associate, of course, with data, because this is what artificial intelligence will integrate. So we need to be very careful when sensitive health data are put on a website, on a web database. And so we need to be transparent with the system, and we have to believe quite a robust network in this regard. This translates in regulatory aspects, because in order to have digital pathology approved and standardized across different countries, and we know the standardization for us is very important, because we cannot compare diagnosis if the system is not standardized, and we cannot run clinical trials, we cannot compare clinical outcomes. We need to have regulatory bodies that will take care of how artificial intelligence tools are developed, how they are validated clinically, and once again to the diagnostic accuracy study, and then with the need for certification and audits. Of course, this is a technology, and we can assume will be a technology with very frequent update and improvement of the system. So of course, we cannot just switch to more advanced system without any check and test. There are technical limitations. Of course, the first, as I mentioned, you cannot train an algorithm if you are not a super expert, because you need to train with the best of the knowledge to allow the system to be reliable. And second point is that for cancer diagnostic, particularly, there is a huge heterogeneity. Also, comparing study, which kind of tumors you have studied, the amount of tumor cells, how easy they were to recognize in the real life. So the interpretation of a data is still to be properly defined. And then, not trivially, honestly speaking, it was true also for robotic surgery. There is skepticism, particularly, let me say, the older generation of pathologists, they are used to a certain job, they rely on their skill, could be difficult to introduce the system that not by chance is currently more appreciated by the younger generation. Last but not least, the economical impact of artificial intelligence, because if I ask you to start digital pathology today, of course you have to invest in a scanner, for example. You have to buy scanner, they are quite expensive, but we could consider a projection which this investment will be translated in advantage in the future, because slides are then scanned, you don't need to store the slides materially. By the way, you should pay for storage them for your gigabase, but you can share, you can develop, and I think in the long term, there would be an economical advantage. Very practically, as I said, you need to buy, first of all, a scanner. It can be an automated scanner capable to manage 1,000 slides per day, but can be even a more simple system that should be then paralleled by an artificial intelligent algorithm. So you should be careful when you buy the system also to care of what is offered and can be applied then to this system. Very importantly, we must develop guideline and standardization and create the network for telemedicine. Indeed, this is quite important in my view, because not only digital pathology could be then introduced in the routine pathology work out, but this can be the base for pathology specialties. You know that surgeons and clinicians, they are divided. We have cardiologists, we have thoracic surgeon, still pathologists, even from an hematopathologist in large part of pathology departments, we have general pathologists. But in 2024, this is failing, very common. No offense, no blame on anyone, but basic pathology is not specialist pathology. And of course, in a small hospital, you cannot have 15 pathologists, one capable to see 10 cases per year because of a specific disease. But telepathologists would allow any center to have a consultant for a very specific field of disease and pathologists like neuropathology, hematopathology, and so on. So I think this would be one of the major applications of digitals. And quite relevant will not be only matter of pathologists, but then the artificial intelligence is promises to integrate the multiomic so that whatever we get from blood, genetic analysis, what we get from the clinical setting, radiology and clinical evaluation will be put together with the pathology investigation in order to put together and improve our diagnostic capability. But I don't want to take too much of your time, so let me thank you very much for the attention. Thank once again Professor Isidoro for chairing this session with me, and Ms. Frida Hu for the tremendous efforts in organizing everything, and of course my group here at the Biobank of Research in Bologna and our research group. So thank you very much, and we'll be glad to take your questions. Thank you.